Hi, everybody. We're going to just give a few minutes and have people sign on, and we'll get started. In just a moment, I'll share my screen. All right, let's get this started. One moment. There we go. All right. Good morning, everybody who is here on the West Coast. Good afternoon for people on the East Coast, and hopefully it's still daytime wherever everybody else is. And thank you all for joining. This will be recorded in case you would like to listen to it afterwards, or if you know anybody who missed this, I have also will send a link to the recording of this webinar. Thank you all for joining me. I'm Tara McCannell, and the webinar that I'd like to share with you today is Eyes Wide Open, Keeping the Best Possible Vision After Ocular Melanoma Surgery. I want to share with you my disclosures. I'm a professor of ophthalmology at the University of California, Los Angeles. I am the host of the podcast Finding Your Way with Ocular Melanoma, and you can find all the past episodes on many topics that really are related to how you're doing, questions that a lot of people have after treatment. I'm also the founder of a recent ocular mentoring group. It's called OMG for for Oncology Mentoring Group, where I mentor people who are in this field, other ocular oncologists who are fewer years out into training and who need support. And I'm also the founder of Say Heart Wellness, which is an acupuncture for anxiety studio in Santa Monica. So I want to tell you a little bit about myself before I go ahead. Who am I and why am I doing this? I am the director of ocular oncology at the Stein Eye Institute at UCLA, and I have been an attending ophthalmologist at the Jules Stein Eye Institute since 2004. And my practice centers on adults with intraocular tumors as well as adults with diseases and surgery of the retina. I am our department's chief wellness officer, so I also institute programs to help support the well-being of my colleagues, as well as our staff, faculty, and students. I'm also the director of our vitreoretinal surgical fellowship training program. That's the 2-year program where ophthalmologists are trained to become retinal surgeons. I did my own vitreoretinal fellowship at the Massachusetts Eye and Ear Infirmary at Harvard Medical School, and I did my ophthalmology residency at the University of Toronto in Canada. I did my Doctor of Medicine, my medical school degree, also at the University of Toronto in Canada, and I did a PhD in molecular biology between residency and fellowship at the University of Toronto, Canada, as well. One of the things that is very important to me and what I've learned over the years of my practice is that information for patients is critical. So I'm a big believer in providing information. Information helps people do better. The more you understand, the more you can navigate something that is new and unfamiliar, the better you will do. So I want to share with you my resource page. I have a QR code. Feel free to scan it or just go to the website. It's sayheart.com/ocular melanoma. And on this resource page are things like A recently published book, which I happen to have a copy right here. This is a handbook that I've written for patients and families who are undergoing or who have recently been diagnosed with ocular melanoma, people who have questions. It's geared to understanding this from a level where you might not know anything. And the idea is we need to have an easy to access source of information so that people understand what they're going through. Unfortunately, the internet has lots of information. Some of it's accurate, some of it's not. But I'm hoping that this book can be a starting point for people who are starting to navigate this, in a starting point where you will begin your own learning in everything possible with this journey. I also have the podcast episodes that I've been doing now for a little over a year. I have links to all past videos and webinars, recorded lectures. The last webinar I did was in February, and it was on mindset in cancer survival. And the first webinar that I did back in December is on a holistic approach to ocular melanoma. So please feel free to find those and use them as a resource. I also have updates, so if you want to share your information, I'm happy to update you on the next webinars that are coming up. I also have a support group, which is a small group where I lead people twice a week in sort of a several week format. If you really need more support, if you need more personalized information, if you have things that are bothering you, the idea is to help give people more control over this and do it with guidance. And so my next guided support group, and this is the last one I'm going to do until maybe the end of the year, starts next month, Sunday, May 4th. And as I said, the idea is to help give you control, more clarity, and joy in this journey with ocular melanoma. There's personalized, in-depth information. I will teach you tools to help you reduce anxiety around all aspects of this cancer. And the idea is to give you more confidence and to help change your mindset and your outlook on ocular melanoma so that you can live your best life. Encouragement, support. There's a like-minded community of other people who want to be in this space. And I find that it is so helpful to be in a group of people where you can share and people can share their own experiences that benefit the group. And so others who have taken this say that this is the best decision I've made since diagnosis. My outlook on ocular melanoma has completely changed, and I have a fountain of information and to continue my learning. And I think this is important to share because other people have had tremendous benefit from this. So if you're on the fence or thinking about it, just save the date. So I want to start with just a summary of what I'm going to talk to you about today, keeping your best possible vision. We're going to go through in a lot of detail, understanding how you see, how you think about how you see, the ways that your vision can be affected, making sure that you are properly monitored, and giving you an action plan for the best possible sight. Let's start with understanding how you see. Let me go through with you what the eyeball is made up of. And this is something that maybe some of you have come to a good understanding of, but I have to tell you that most medical doctors have no idea what is behind that color part of the eye. It is truly a black box, and in medical school training, we don't go through ocular anatomy in much detail at all. So chances are your own doctors who are looking after other parts of your health don't understand this. So that is why it is important that you know every single thing. And I will go through in this talk why it's important to understand everything, because everything has an explanation. Every way that you see, every disturbance or something that's different, it has to have an explanation. And you will understand this if you understand the anatomy of the eye. So this is a cartoon of the eyeball, and you can see that oblong white structure a little bit to the left. That is your lens, and that's what forms a cataract as we go through life and get older. So everything to the left we call the anterior chamber. This is the front part of the eye. and everything to the right into the red part we call the posterior chamber. So the anterior chamber is made up of the cornea, which is the clear cap that covers this little chamber in the front, which we call the anterior chamber. The liquid behind the cornea is called aqueous humor, and that is essentially like water in the front of your eye. Your pupil is that circle that is surrounded by your iris, and the iris is the color part of your eye, brown, green, blue, or a combination of both. And it is a thin structure that lies on top or in front of your lens. All of that is what makes up the anterior chamber of the eye. Let me continue here. If you were to develop a melanoma of the eye, uveal melanoma, ocular melanoma, choroidal melanoma, all of those things mean the same thing. The melanoma forms in the deep layers in the back of the eye, in the posterior chamber, and it forms in the choroid. And the choroid is depicted here by the blue layer. In front of the choroid is the retina, which is the neural tissue that has photoreceptors and accepts signals of light that are transmitted, and they all come together at the optic nerve, which you can see here, which leaves the eyeball. And all those neurons and nervous tissue that make up the optic nerve go back to the brain and give you your vision. So let's talk in a little bit more detail about the cornea. And the picture to the right, the cornea is depicted by that clear cap. And you can see that it is clear when you look in the mirror, it just looks like, we call it the color part, but really the cornea is the cap, the iris is the color, and that's inside the cornea. And the lens is what is next behind the iris. So if you look at a person, you're talking to them and you see their pupil, it looks dark. But if you use the instruments that we use in the ophthalmology suite, the slit lamp, that microscope that you place your face in, that allows you to actually see the lens and the health of the lens. So the front of the eye, the cornea, can be bothered by a few things. I want to mention dry eye. Dry eye is one of the most common problems that can affect people, no matter what you have, whether you've had melanoma, whether nothing has ever happened to your eyes. Dryness of the eye is when we don't make enough tears, or there may be an irregularity of the surface of the eye that causes tears to evaporate faster. There's a picture of a person here looking off to the side with vessels looking a little red. When a person has dry eye, their eye often feels gritty, may feel uncomfortable, and it may look red, and the vessels may look a little reddish like this. This is dry eye. And what can you do about dry eye? There's a whole host of treatment algorithms for dry eye. The easiest and simplest thing that helps most people is to use artificial tears. As we get older, we make less tears, and when we supplement with artificial tears, it gives us great relief. So one of the other things that can affect the cornea is astigmatism. Now, what is this sort of bizarre word that sounds bad? And whenever anyone says astigmatism, it's such an ugly sounding word that we just think it's the worst possible thing. All astigmatism is that the surface of the cornea, that smooth cap, is not perfectly spherical. It's a little oblong because our eyelids push on it. There may be other things pushing slightly on that clear corneal cap so that it's not a perfect sphere. And when it's not a perfect sphere, it affects the refraction of light that passes through it. So if it's not a perfect sphere, we say there is some astigmatism. And astigmatism is not a disastrous disease. I just want you to take that home. All it is a slight change in the shape. And as we get older, and our eyelids might get a little droopier, they are not as open as, say, when we are in our 20s or 30s, we can get an increased amount of astigmatism, which can simply be corrected by a glasses prescription. And I mentioned it can be related to eyelids, the shape of the eyes. Sometimes when people have surgery, it may change the shape of the cornea a little bit. So these are the things that can affect this superficial outer coat of the eye, the cornea. And again, I want you to understand all these parts of the eye so that you can know in your mind what is going on when you experience changes in your vision or you have symptoms. So let's talk about the lens. I mentioned that there's the cornea, there's the liquid behind the cornea, which we call aqueous humor, and then there's the iris, which is the color part of the eye, and then just behind the iris is your lens. So the cartoon here on the right can show you exactly what I said, and I'm going to highlight the lens here in this picture of a patient here. This is the only way we can assess the lens. And we assess the lens because we want to understand what is the amount of cataract or how much cataract could be the factor influencing your vision. And so in this picture, the lens, let me just put this for a comparison. There is a slight cataract here because the lens isn't crystal clear. It's a little bit whitish, and that's when a person has a cataract. Now, cataract, as I will say throughout this presentation, is a normal thing that happens to everybody if we get to live long enough. We begin to see the start of cataract in people when we cross 50, even though it may not interfere with your vision or need to be corrected in any way. When we examine people at the slit lamp, most people, by the time they are 50, we see just the beginnings, barely anything of cataract. The commonest age that people need to have cataract surgery is around 72 to 75, but of course that varies. Some people develop cataract earlier and others late. So you really have to pay attention to your own symptoms. What are the symptoms of progressing cataract, which is change of the lens? It is generalized, mild, gradual blurring, where you just notice that the details are not as sharp and crisp, particularly for things in the distance, as well as an increase in the amount of halos that you might see around lights at nighttime. And for people who start to get this symptom of cataract, they find that it's difficult to drive at night because of the halos and the glare. And they may find that they're avoiding going out at night just because it's troublesome. And these are real symptoms of cataract. And with any of these symptoms, it's a reasonable idea to go ahead and have the cataracts treated if it's interfering with your life and you want to see better. Which brings me to cataract surgery. And, I have up here the lens, we're born with it and it becomes cataract in time. And really, cataract surgery is the most commonly performed surgical operation in the world performed by an ophthalmologist. It is an excellent treatment for something that is a very normal condition. A lot of times when you say the word cataract for the first time for a person, we associate that with, oh my gosh, I'm falling apart, I'm getting old. But cataracts are just one of those benefits of getting to live a long life. So I look at cataract as something that will hopefully happen to all of us in time. And the surgery is phenomenal. It's outpatient. Recovery is usually just a couple of days, and most people notice vision improvement in just a few days. And I tell people, don't delay if you have symptoms of cataract. Don't put it off, especially if your vision is getting worse and worse, because it can change your life. Of course, people are worried. We don't always just jump in and do surgery on the eye unless we feel that there's something that we can correct. Even in the rare instance when people have complications with cataract surgery, almost always they can be corrected and people can be brought to good vision. But cataract surgery complications are extremely rare. And if you are contemplating having cataract surgery, just be sure that number one, your cataract surgeon is very comfortable and does literally hundreds or thousands of these operations. And two, that your cataract surgeon is not hesitant or doubtful or afraid of operating on you. If you have a surgeon who's afraid of helping you, please get a second opinion and find somebody who is enthusiastic and wants to see you do better. Just a general rule. So what happens in cataract surgery? You have an artificial lens implant that replaces the space. So if you see on this diagram, there is this flat artificial synthetic lens that sits in the exact position that your natural lens, where it used to be, the intraocular lens. And most people notice immediate clearing of the vision. Sometimes people notice that the sharpness that they had right after surgery declines a little bit after a couple months, and that is often thought to be related to changes in the vitreous humor, which we'll talk about in a moment. And sometimes after several years, the vision may get a little blurred and it may seem like you're seeing through a film or a gauze. And this is due to the opacification of the posterior capsule. What is the posterior capsule? That is the natural bag that holds the lens implant. And so here is a picture, a photograph at the slit lamp microscope of what it looks like when the posterior capsule opacifies. You can see that artificial lens is there. You can't really see it because it is totally clear, but you can see that hazy film that is behind it. And when that is in front of your vision, you're going to start to see less clearly. We can treat that with something called a YAG laser. And you come in, and a YAG laser takes usually a couple of minutes and it's done. And usually later that day, you will notice the improvement in clarity. So all these things can be treated. These are all the explanations that could be behind why you're not seeing as clear as you'd like to be. And sometimes after cataract surgery, now it's maybe 5, 10 years later, you may notice that your vision is a little less sharp, not as clear. Usually, this is due to some astigmatism, which is this change in the shape of your cornea. Your lens is still working well. Everything may be clear, everything may be healthy, but you might want to touch that up with new glasses because if there's a little bit of droopiness of the lid or the shape of your eye has changed ever so slightly, a change in prescription can often sharpen things up. And I tell people after you've had cataract surgery, you should think about getting a glasses update maybe every 2 to 3 years just to keep things as sharp as possible. Okay, so let's move on. We've talked a lot about things in the front of the eye, and hopefully that's given you some more thoughts to think about how to explain some of the changes that you may be noticing yourself. We're going to move to the posterior segment. Okay, the posterior segment is the domain of the eye where a retina specialist has their expertise. So we're going to talk about everything in the back of the eye behind the lens. Everything we've talked about so far can be dealt with by your cataract surgeon or comprehensive ophthalmologist. But now we're moving to the back of the eye, and this is really the expertise of a retinal specialist, a retinal surgeon. So let's talk about all the things that can happen in the back. Okay, here is a photograph that you may take at an optometry office, an eye care provider, where they take those photos where you stick your head in that white box and they take these pictures that capture nearly all of the retina. Note that it's not 100% of your retina. It's anywhere about 85% of your retina, which is a good amount. And oftentimes, these photographs are excellent screening tools that can pick up small abnormalities before they become symptomatic. And many of you, people who might have been treated or diagnosed with an ocular melanoma, might have had these photos taken just routinely in order to just do a scan and then something is found. And these tests have picked up a lot of disease earlier than we would normally see them. So let's talk about the normal human retina. This is pretty normal. All the vessels look generally intact, and this sort of pigmented, there's a sort of mottling, this brownish color interspersed with the red. That's just the normal pigmentation of the choroid, which is the layer under the retina. And that white circle in the very middle is your optic nerve. All the nerve fibers come together and go into the nerve to pass out of the eye and take messages to your brain. Now, let me show you. This is the macula. So when people talk about the retina, it's a very general term, but the retina itself is made up of the macula, which is this area in the very middle. The macula is only about 15% of the whole retina. And then the rest of the retina, we may call the peripheral retina, or what's responsible for your side vision, your vision just outside of your central vision. And I'll talk about this quite a bit, but a lot of focus and emphasis is only on the macula. But we have to remember that 85% of the whole human retina is not macula. So we have to look at everything. The macula isn't the only place that gives you vision. It's your entire retina that gives you your whole visual picture, particularly your side, your peripheral vision, and your ability to navigate. Your ability to detect light is sharper with your peripheral retina than it is in your macula. And just an example, if you go outside on a dark evening and you're looking at the stars, you may notice that you can see a twinkling star slightly better if it's very small with your side vision than when you look straight ahead at it. So your peripheral retina is really important in navigating, helping you get around and seeing things that you just might not notice with your central vision. It's all very important, which is the bottom line. So let's talk about the vitreous cavity. So this is that whole space that is behind the lens and that fills the whole eyeball, which is like a little, like a small sized golf ball. The retina that we talked about is the inner lining. But what about all that space? This space is filled with vitreous humor. And a lot of times people can get opacities in the vitreous, and we call those opacities floaters. And for people, they can be very different. They can be blobs, dots, strands. You might notice sort of a vague cloud or haze that might follow your gaze and that is mobile. That is key when we're talking about vitreous opacities. When we're born, the vitreous humor is a transparent solid in utero, so during development, when the baby is being formed, the vitreous is actually filled with vessels. It's filled with blood vessels that are forming all parts of the eye. And by time of birth, all these vessels have regressed and have become a transparent solid gel. So there's no more vessels anymore. And so this gel is what fills the posterior segment of the eye. So throughout life, the vitreous humor naturally evolves to contain increasing amounts of water, and that we call vitreous degeneration. Now, people can have floaters that may be gradual with vitreous degeneration. However, sometimes floater symptoms may be acute, when enough water content of the vitreous causes the vitreous humor to separate and fall from its attachments to the retina. And when people have this acute vitreous separation, or we call it posterior vitreous detachment, there's usually a sudden onset of floaters. Or you just might notice a bunch of floaters that you know are not really there that just come out of the blue. It's important that if you notice any acute change in your level of floaters or in your vision, that you have a thorough retina examination because you want to search for things like a retinal tear or retinal detachment. And these things require urgent treatment, urgent surgery. So be sure that if you notice anything new that isn't just part of your background normal symptoms, that you be evaluated carefully. And I always recommend a retina specialist because they know how to look at the entire peripheral retina. Sometimes people get photographs to check on the peripheral retina. They're better than not doing anything at all, but you need to have that examination where they use a probe and push around the eye in a circle to look at all edges of the peripheral retina. So these are just examples of what vitreous floaters, opacities, degeneration may look like. And the reason that there's a simulated picture is because a lot of times the ophthalmologist might not be able to see what the patient is noticing. And I find that a lot of times, sometimes we see obvious floaters, like on the left, there's a picture of a strand of vitreous that is captured in this photograph. But a lot of times, a person, you just can't tell how much the floaters are bothering a person unless you ask and find out how the floaters affect their vision. So what do we do about vitreous floaters, vitreous opacities? And this is an important topic because they do affect so many people and they can affect people's vision. In the majority of people who have vitreous floaters, observation is all that's needed. And, Usually, if floaters are acute, they will get a little better over the course of a few weeks. It's important during this time to get checked by a specialist. Now, sometimes the floaters, they improve, but they're kind of there and they may bother you periodically. There's some things that you can do to reduce your perception of your vitreous opacities and floaters. And here's a few that you can try that often work in patients that I've talked to. Reduce caffeine intake. A lot of times when you have caffeine, a lot of coffee, you increase your sympathetic drive. And the more your sympathetic nervous system is activated, the more you're going to notice things in your vision. So if you can manage your response to stress, like practice meditation on a regular basis, you will actually reduce your sympathetic response and encourage your parasympathetic response, which is that relaxation, digestion when you're in a more calm and grounded state. Some people even find that acupuncture can improve your symptoms of floaters. And how might this work? Well, acupuncture overall helps increase your parasympathetic responses and reduces your stress response. So these are just things to try that are very safe if you want to see if you can alter your perception of bothersome floaters. Now, there are people whose floaters of the vitreous are debilitating, meaning that a person no longer feels safe driving anymore because floaters come right in front of their vision, or that they're just not able to perform and be productive at work. Because oftentimes, if you need to read, floaters might drift into the center and people find themselves shaking their head a lot to try to see around it and just are not as productive. So those are the two things that if a person feels impaired and they can't function properly, we will consider doing surgery to remove the vitreous opacities. And I want you to know that if you go on the internet and read about surgery for vitreous floaters, you will find that it's dangerous, that we never do it, it's a serious operation. Yes, every operation is serious, but if you're not able to function in life anymore, the degree to which vitreous opacities can impair your vision can be worse than some of our common retinal diseases. So, in my view, I consider debilitating vitreous opacities just like a disease, like anything else that we would treat so people can do better and function. And particularly if you have your other eye is weaker and maybe it doesn't have as good vision for maybe you had a melanoma treated, or maybe you've had macular degeneration, or maybe you've had a retinal detachment and you're relying on the eye that's healthy. As time goes by and if you do get worsening vitreous opacities, these are the kind of people that having surgery to remove them can be very beneficial. So you definitely don't have to do that, but I want you to keep it in mind as an option because some people just feel better knowing that there's something they can do about floaters. And I mentioned that they can impact a person more so, particularly if it's in the better seeing eye. And as I said, bothersome floaters can be worse for people than the effects of other types of retinal disease. So besides just opacities of the vitreous cavity, what else can blur your vision when the vitreous cavity is involved? One of the things is blood. So if you notice that suddenly you can't see, maybe there's a whole bunch of floaters in your eye, it might not just be degenerated vitreous humor, it could be something else, such as blood. And when there's blood in the vitreous cavity, we call that vitreous hemorrhage. And there's a picture here of a very light vitreous hemorrhage, so you can still see the retina underneath. But when people have a vitreous hemorrhage that really drops their vision and they feel they can't see, neither can the ophthalmologist see when they look and examine the patient. And why can you get blood? Blood can come from abnormal vessels of the retina. For example, if you have new growth of abnormal vessels, we call this neovascularization, these abnormal vessels can bleed. And why would you get this? Eyes develop neovascularization if there is ischemia. So if you have damaged retina that doesn't have proper blood flow, the eye will want to grow new vessels to kind of fill in and to help re-nourish the eye. But these new vessels can be problematic and they can bleed. Examples of when we might see this: radiation retinopathy, particularly in people who are younger. So people who are in their 40s, 30s, who may have radiation retinopathy, it's really important to check the circulation of the retina. Even when everything seems normal, when there's no symptoms, the vision seems fine. And you can check the circulation of the retina by doing the fluorescein angiogram, that dye test that turns your urine yellow or bright orange. That can tell you the health of the vessels. And when we find areas of ischemia where there's not enough blood flow, doing laser treatment can minimize the development of these new vessels that can bleed. Another more common condition is people who have diabetes and have diabetic retinopathy. They also can get areas where the vessels are not working and the eye produces new vessels, which can be problematic. Other reasons that you can get a vitreous hemorrhage, you might have a cluster of abnormal vessels that just suddenly leak vessels. For example, you might have a lesion of the choroid that is sort of like a hemorrhage, like a choroidal hemorrhage that just bursts through and it leaks blood, and then it will go away, or it may need to be cleared. But it doesn't mean that the rest of your retina is sick. You might have what we call a macroaneurysm. Sometimes people who have hypertension have a little aneurysm of a retinal vessel, so it pooches out like a balloon and then it pops and then you get some blood, whereas the retina overall is healthy. There could be a mechanical reason. If your vitreous suddenly separates and you have this vitreous detachment, vitreous separation, there can be parts where the vitreous is stuck to the retina that suddenly pull away and you get a little bleed of the retinal vessels. And then, if you've had a melanoma treated, your tumor usually continues to evolve and form a scar, and there can be necrosis of a dead treated melanoma that suddenly causes bleeding in the retina. So we want to always look at all these possible causes and sort all this out. And sometimes right after vitrectomy surgery, a person can get some blood in the eye. Usually just monitor that because that will go away quickly. So if you have blurring and you're thinking that maybe it's something in the vitreous cavity, these are things to understand what the possible causes may be so that you can understand, your doctors can sort through things and figure out the best way to get you seeing better. So I mentioned, how do you treat blood or bleeding into the vitreous cavity? It really depends on the cause. And this can be a challenge because if there's enough blood, you really can't see the retina and you might really not know. You can do an ultrasound, but that will only tell you if there's a detachment, no detachment, if there's a tumor or no tumor. It won't tell you really the health of the retina and the circulation very well, in fact, at all. So we have to use clues. And that means we mean your retina specialist, your ophthalmologist. They have to be looking at all these things. So what do we do to check to try to figure out why you're having this bleeding? We're going to review any past surgical procedures. Okay, if you've had a recent vitrectomy, maybe this is right after surgery, look at past images. What imaging studies have you done? I know in my practice, we do a lot of these fluorescein angiograms so that we can go back and see and we can tell if is it the beginning of the vessels starting to look sick? Do the vessels look perfectly healthy 6 months ago? Because if they look healthy, then we have to search for another reason. I mentioned we perform ultrasonography because we still want to know gross information that all the structures are grossly intact. It's likely that your doctors may want to do a short period of observation, but it's important, especially if it's blood that no one seems to know why is there, that you have a vitrectomy. And vitrectomy is the surgery where we go in and we clear out, we remove the entire vitreous cavity and replace it with normal saline. And by now, you may understand that we actually don't need a vitreous humor after we're born. And it does contribute to lots of different retinal diseases as we move into the later parts of our lives. And the reason we want to move more quickly to surgery than just to leave it and keep waiting and watching is because doing surgery allows us to treat a possible underlying cause that will improve vision. And also, having surgery to remove the blood is going to immediately improve your visual situation than just watching and waiting and letting the weeks go by. In the olden days, like 80s, 90s, before we had the techniques that we do for retinal surgery, monitoring was really the only thing people did. And people waited months waiting for the blood to clear. But unfortunately, a lot of ocular morbidity can occur if we don't act quickly and address the problem. What are other reasons that you can get blurring of the vitreous cavity? Inflammation. So inflammatory cells can also cause floaters and be a reason that the vision is slightly blurred. And when things are inflamed, the actual vessels of the retina start leaking, and we can see the leaking on fluorescein angiography, but also actual white blood cells are leaking in to the vitreous cavity. And we also see a spillover of these white blood vessels in the front of the eye when we look with the slit lamp. Usually it's uncommon to have inflammation, but if a person has had a surgery where the eye is still recovering, there can be post-inflammation blurriness, or you might have a totally different condition where there's inflammation of the vessels of the retina. And there's a whole subspecialty of ophthalmology where people deal with inflammations of the eye. What else can cause blurring of the vitreous? Pigment cells. So a lot of times, if a person has a larger sized ocular melanoma that's been treated and that's dead, this dying and dead tissue can shed pigmented cells into the vitreous humor. And these are inert, inactive, they do not cause elevation of the risk of metastasis. They are not a sign of the cancer coming back. If we see pigment in the vitreous with a dead tumor, you can observe it if it's not really bothering your vision. But over the years, I definitely have seen where all this pigmentation starts to bother people or certain individuals, and then certainly we have vitrectomy to remove all of that so that your vision can be clear. So let's talk about some other problems of the retina. And as I said before, the retina is made up of the periphery, which is about 85% of the retina, and then the macula, what you see here on the box, and that's your central vision. And the retinal periphery, in my view, doesn't get enough attention. We have so much emphasis on the macula. But the peripheral retina is where, if a person develops a garden variety retinal detachment, that usually starts in the peripheral retina. The macula can be affected by various conditions that are far more common than ocular melanoma, and I'm going to go through these. So let's start with peripheral retina retinal detachment. So this is a typical picture of what a significant retinal detachment looks like. So you can see this is also taken from those photos, the Optos photo, where you put your head in the box and capture the whole view of the retina. So when we examine patients in real life in person, we don't get this whole picture snapshot. We get sections when we examine patients, certainly as a retina specialist. And we look at all the locations of the eye. We look at everywhere. We see where the retina is detached. We see where it's attached. And here in this picture, you can see there's a big hole, that flap sort of there, right here. This is a tear in the retina. And the tear in the retina is what allows the liquid in the vitreous to get into the hole and start to peel everything back. And you can appreciate that this is all detached retina, where it's all hanging over, and it should be like this at the bottom where the retina is attached. So this is what a retinal detachment looks like. And retinal detachment always starts in the periphery. So it starts with a tear. That the tears of the retina are almost always in the far edge of the retina, and the tear will gradually progress towards the center, where if it continues, it'll impact the entire vision. And this situation requires urgent vitreoretinal surgery to repair. Let's move to the macula. And as I said, the macula is the central part of the retina. And here is a picture that many of you probably have seen. This is called an OCT. That's the type of imaging this is. An OCT stands for optical coherence tomography. OCT has literally transformed the practice of retina. It has allowed us to see things that we just cannot see naturally with the naked eye using our lenses. It almost allows a histological section of all the layers of the retina. And you can appreciate that there's at least 12, 13 different layers, and each one of those layers is a part of the retina that contributes to your vision. Now, because doing an OCT test has become so much part of our everyday care, you may get an OCT scan with your retina specialist, you may get one with your general ophthalmologist, you may get one as part of preparing for cataract surgery, and a lot of optometrists now perform OCT scans as well because it's such an easy way to do a quick screen of your macula. But I want to point out, with all this emphasis on OCT in the macula, you can imagine that sometimes we're forgetting about the importance of the rest of the retina. But now you know this is only a small part. We have to remember the whole picture. But for now, let's focus on the macula and conditions of the macula. Let's talk about age-related macular degeneration. This is really one of the most common conditions that a retina specialist sees. And this is a common condition in people over the age of 65, 70, over 70. And to the left is a typical OCT appearance of someone who has dry macular degeneration. Those little bumps are what we call drusen. And this person on the left may have minimal impairment of the vision. They might notice that they need a little bit more light, but this person probably sees pretty well in most conditions. To the right is a situation where we have wet macular degeneration. And wet macular degeneration is when there are abnormal vessels deep in the choroid that just bleed. And we still don't know exactly why this happens. We certainly understand a lot of the pathways and the molecular mechanisms that are responsible, but how this all happens and why it happens is still not clear. However, when you see and you do an OCT and you see this in the macula in someone who has new onset decreased vision, we can immediately treat. So the most effective treatments we have for macular degeneration are when people develop wet disease. And it's really important that wet macular degeneration, the sooner we treat it, I mean, the more minimal the symptoms are, the better people do. If we wait till it progresses quite a bit or the vision has fallen a lot, it's harder to get noticeable improvement. So another reason it's so important, if you notice a change in your vision, you have to look at everything. And let's talk a little bit about more about macular degeneration. 90% of people who have age-related macular degeneration have dry. Having the wet form is much less common. And if you have the dry form of macular degeneration, the majority of people who are found to have a few drusen have very minimal to mild symptoms. However, there is a small percentage of people who have dry disease where it's so thinned out that they have severe atrophy, which can drop the vision. Now, if you have wet macular degeneration, this is the one that bleeds and leaks. It is a far smaller percentage of people who have macular degeneration. And these people need to be identified because they respond well to injections, the medications that we receive. One thing I want you to remember is that age-related macular degeneration is usually not progressive. When someone sees a little dry disease and they hear about it through their eye care provider, it is usually met with much alarm and fear because they're assuming that eventually they're going to lose all their sight. I want to assure you that this is incredibly uncommon. The majority of people who have mild dry disease tend to stay about the same over many years. You still need to be monitored, but it's important not to have this idea that one day you're going to lose all your vision. We have so many good treatments. Monitoring can happen, early intervention, being on top of your condition. The majority of people with this now do very well. Let's talk about some other causes of fluid in the retina and the macula. So retinal edema, this is a common thing that can happen in people who have diabetes, as well as who have radiation macular edema. Obviously different causes, but it's when those small blood vessels leak, and then we see on our pictures that there is edema of the retina. I want to talk about what a macular pucker or epiretinal membrane is. It is literally a membrane, which is what the blue arrow points here, that scrunches up your macula so that your vision is distorted. And this is treated by surgery, where we literally peel off that membrane like peeling off a price tag so that the tissues can relax and regain that nice dip down appearance of a more normal OCT foveal contour. And here is a picture of a macular hole. All these things are reasons that your vision may be down, and it's important that your doctor check. That's why I think it's important that you know some of the basic reasons and causes of decreased vision. So macular hole is when there's literally the very center has separated. And again, this can be repaired with surgery. We can put this together. Let's talk about how we measure vision. We use Snellen visual acuity, and we call this the 20/20 vision. And what 20/20 means is that it's what a person sees at 20 feet what the average person with normal vision can see at 20 feet. So it's just a description. And when we do the pinhole vision test, it restricts light rays and it result in improved vision. So when they use the pinhole and you do better, it means that you have a refractive or an optical reason that you're not seeing as well as you could, but that we can do things to get you seeing better. We also test vision by doing visual field testing, which tests the peripheral vision. However, we also have contrast sensitivity testing, which measures your ability to discriminate in light and dark, for example, driving or reading in low lighting conditions. However, when you go to the eye doctor, the focus and emphasis is really on that Snellen visual acuity. What are you, 20/20, 20/30, 20/80, and all the other things, the periphery, contrast sensitivity testing, which is outside of the artificial environment when you're testing your vision, we actually don't test for that in a busy eye clinic where your people are, there's a lot of patients. We focus on the Snellen. And now you can see that the Snellen isn't the whole picture. And it's really important that the way we measure vision is somewhat limited. So if you have a certain thing that's bothering you, even though you're 20/20, you need to verbalize that. And you need to make sure that your eye care provider hears your concern and how your vision is being impacted, because that will make a difference with whether you're going to get any treatment or not. If you don't say anything and they see 20/20 in your medical record, it may stop there, but you must communicate how you're seeing. As I said, it's not the whole picture. And the other thing, now that we have these OCT tests, there is so much emphasis placed on the OCT result, whether you're getting injections for radiation retinopathy, people are just looking at that and making decisions. But now you know that your vision is affected by everything else, not just this little tiny patch of the retina. So your vision is not just Snellen acuity 20/20 or the OCT. It's really the sensory input you receive from both eyes simultaneously. The message that is received in your brain and how you perceive that. That is how we see. So it's important. The ways that doctors measure vision and come to conclusions about your vision may be flawed if you don't share the whole picture. So if you only use these objective things, we're going to miss a lot. So please verbalize anything that you notice to your doctors so they can help put it together and you can understand it. So, what is vision? How do you see? It's really the photons of light that stimulate your visual receptors. So you receive stimulation from an eye that has disease or an abnormality, you receive it from a fellow eye, and then it's all the inputs putting that together. So we don't understand exactly how that's integrated in your brain, but it happens higher up, and how you fit things together gives you the meaningful image of your surroundings. So this is this integration, and how we see depends on also our attitude about this sum total of your vision. So how you think about how you see. And that leads me to an example that I just want to share. I had a lady, older lady came in, she's 78, routine retinal evaluation. She had no concerns. Her vision was 20/50 in both eyes, and her exam showed that she had mature cataracts. So that's why her vision it wasn't 20/20, it was 20/50. She had stopped driving quite a while ago and she was very happy. She could do all her activities, she could meet with her friends, everything was really in good shape with her. We talked about the fact that she did have cataracts and that maybe one day in the future she may notice that her vision gets worse and maybe cataract surgery was to be considered. But she was very happy the way she was, so we just continued to observe her. And this is someone who has 20/50 vision in both eyes. Now contrast that with a 52-year-old male who came in for a second opinion to see me, and he had recently had a treated ocular melanoma somewhere else, and he wanted to just discuss how he was doing. His vision was 20/50 in his melanoma eye, and it was 20/20 in his unaffected healthy eye. And his exam revealed that he had some atrophy around where the melanoma was that was the reason why he couldn't see 20/20 in the melanoma eye. And he told me that his previous eye doctor had said, unfortunately, you have lost some of your vision in the treated melanoma eye. And this patient himself was really bothered by it because the ophthalmologist was disappointed in the visual outcome. And on further communication with the patient, he had resumed his regular activities. And when he wasn't thinking about his lost vision, he was functioning well. So the plan really was to continue his monitoring and to sort of shift focus on his overall health because we can't do anything about a melanoma that happens or if there's some thinning of the tissue because of the treatment, but there are other things that we can focus on to keep ourselves healthy that we do have control over. And so this leads me to the section of what I want to talk about is how we think about how we see. And I've said this in past webinars, but your attitude, how you decide to think about your situation is very important. And it is something to reflect upon and to think about making changes if this will serve you best. So, how you think about your vision. How you think about your vision can change the course of your life. And why is that? Because your thoughts, how you think about something, determines your feelings, and we choose the actions that we do based on how we feel in our lives. When something happens in life, we can choose how we will think about it. Our thoughts can be conscious and intentional. The situation of losing vision or getting cancer or a new diagnosis or something just happening to us in life is no different. We can still choose the thoughts about what is happening. Now, let me illustrate this to you. And by the way, this is something we found in research that was published in the Journal of Behavioral Medicine in 2020, that how well people did after ocular melanoma treatment, their perception of a favorable outcome was not affected by the actual visual acuity. So it is possible to have a favorable outcome and not have perfect vision in a treated eye. So let's talk about your thoughts about your vision. So some things that happen to us are out of our control. That's like the fact that it rained yesterday. This could be you got diagnosed with an ocular melanoma, or there's disrupted tissue in your eye impacting your vision. These are just circumstances and objective facts. However, how we think about it is your choice. Here's an example of an unintentional way to think about decreased vision. It sucks to have a damaged eye. My treated eye is less than perfect. This is a tragedy. Or you can be more intentional and decide to look at it a different way. You can say, look what I have from this eye. Even though it's a weaker seeing eye, it helps me with my peripheral vision, which keeps me from bumping into things on the side. Or you can say, my change in vision is going to be a new challenge for me to overcome, and it will make me show up as my best possible self, the ways that I figure out how to deal with it. So let's think about what these ways of thinking out about our vision change how we feel. When we say to ourselves, gee, it really sucks to have a damaged eye, that makes me feel kind of hopeless. Life is unfair. I'm thinking, why me? It's a very limiting feeling for us. But if we switch gears to the thought of my weaker seeing eye provides me with peripheral vision that helps me with navigation, that makes me feel an appreciation for what I have, a sense of gratitude and calm. And if we think my change in vision is going to be a new challenge from which I can grow, that gives me a feeling of hope and of continued possibilities in life. So here's some things that I think we need to re-educate ourselves with in ophthalmology. 20/20 vision is considered this perfection, and we know that it's not the whole picture. Vision loss, when we say people lose vision or go blind, that is far too vague because, as you know, there are many components to decreased vision depending on what piece of the eye has the abnormality, what structure is altered. There are few conditions that cause total loss of sight. Of course, some people have what we call no light perception. The eye doesn't see anymore, but that's a small percentage of people. And things don't necessarily always progress that way. For example, even in macular degeneration, most people who have dry disease that's mild tend to stay about the same. The other thing that it's important to note is that when you find yourself saying, gee, my vision is kind of getting worse, it must be old age, that's wrong. There is always a reason in ophthalmology that you can't see well. There has to be something that your doctors look at, identify. Your eye is a structure. So if you think things are kind of getting a little worse, don't just say you're getting older. know that, oh, it's a cataract progressing a bit, or it's a little posterior capsule opacification behind my artificial lens implant. There's always a reason. And so if you understand that, you will help your doctors sort that out so that you can do better. And I want to point out these two terms that I referred to before that cause a lot of unnecessary fear and consternation. One is when someone says you have a cataract. That is something that is not the end of the world. In fact, as I said, a cataract is the benefit of getting to live a long life. Age-related macular degeneration. Today, we have such good treatments for when we have the serious types of disease, and there are more treatments coming for AMD. So, not to be too worried, there are ways that you can address these conditions. So let's look at the different ways that vision can be affected. And these are people who can have 20/20 vision. You might have 20/20 vision, but there can still be things that are not correct. And that's why you have to understand. So the eye chart vision doesn't provide the complete picture. You can have transient blurring because of dryness. You may have some glare. You might have some hazy vision. There might be light sensitivity. Overall, it might look blur. There might be blobs floating. There might be something in the middle. Colors might be faded. There might be missing areas in your vision. There can be tunnel vision. And this list can go on and on. There's all sorts of ways that you can describe how your vision is reduced. So make sure that you articulate exactly what seems to be wrong, because that will help guide your ophthalmologist. All the testing, all the images that we do, none of them are helpful without giving clues that you can describe so that we can come right to the correct answer. So articulate your symptoms with your ophthalmologist, figure out exactly what's causing it, understand what you can do to improve or resolve it. So take everything into consideration, even the eye that doesn't have the disease that's being closely monitored. So how do we properly monitor our eyes? It's important to have an ocular evaluation after ocular melanoma treatment. And I recommend that people be seen every 6 months for at least 5 to 7 years by their ocular oncologist. We need to always confirm that the melanoma is dead by our exam and ultrasound. We need to assess for anything treatable that can improve vision, such as cataract, glaucoma, which is elevated pressure, radiation retinopathy, maybe laser treatment for areas where there's poor circulation. And certainly if there's retinal detachment or vitreous hemorrhage, there is surgery that can help you. And of course, look at the other eye. You have two eyes. We need to always be looking at both. So full evaluation. Don't make sure that everyone is zeroed in only on not just the treated eye, but your other eye as well. Make sure just enough time, the same amount of time and attention is focused on the unaffected eye, because you can also get a cataract. Check for glaucoma. We published a few years ago that 8.6% of patients after brachytherapy plaque will develop secondary glaucoma. Make sure that if this is you, that you seek subspecialty care with a surgical glaucoma specialist. So many times I've seen that people are not aggressive enough treating glaucoma, which is a disease that we have treatments for, and vision can be lost in a melanoma eye. Check your retina and macular health. Macular pucker, macular degeneration are common conditions. So who should be checking you after you have your melanoma treated, when you're being monitored, you're wanting to be as proactive as possible? Continue to see your optometrist. These checkups are important because your vision may be improved with new glasses. And I recommend that you continue to see a retina specialist, because a retina specialist may work together with the ocular oncologist, particularly if the ocular oncologist is not retina trained, because retina surgeons can treat common retinal conditions even in the melanoma eye. So what can we do for best sight? Be monitored and evaluated. Understand the changes in your vision. Understand all of your symptoms. Have a plan for each ocular diagnosis, such as glaucoma. If someone diagnoses you with glaucoma and you start on drops, what's the plan? How do you know that you're being treated properly? You must ask these questions. It's very important. See a retina specialist if your ocular oncologist is not a retinal surgeon. Retina specialists have more access to the latest drugs that are coming out, because we're the people who treat macular degeneration, diabetes, the common conditions for which these drugs are initially intended for. And also, there's more access to surgical repair of retinal conditions. We recently had a melanoma patient who had a macular hole, and there's all kinds of grafting techniques that are relatively new in the field of retinal surgery that we can offer to help improve that central vision. So much can be done. Of course, improve your overall health, exercise, nutrition, your sleep quality, improve your mental and emotional health, and continue to work on your attitude towards your vision. How do you think about how you see? Leave room for hope, gratitude, and possibility. We don't completely understand vision loss in ocular melanoma treatment. Only thing we know is that the more radiation in general, the greater the risk that there can be side effects. However, the same size tumor in the same location in 5 different people can have completely variable vision results years later. So we cannot accurately predict vision loss. So this inaccurate ability to predict leaves open a lot of possibility for you to do things to improve your health, to do the best you can. So sometimes, after 5 to 7 years, some patients actually experience visual improvement. What does this mean? It means that it's possible for ocular tissues to recover. So take action to improve your whole body health, to support everything that you can, mental health and physical health. And I want to share with you a case. This is a lady who had been treated years ago before I came to UCLA. She was treated with proton beam therapy in the 1990s. At the time of her treatment, her fellow eye, she already had a history of trauma and she had lost her other eye. So this was her only eye, and her melanoma was, was right in the macula. And I continue to see this person every year. And over an 8 year period, her visual acuity improved from 2200 to 2080. And she told me that she was noticing gradual improvement in her vision. And this is like miraculous. This is hard to believe, but this is a real case. And others, she's not the only one, others who notice visual improvement may notice more improvement in their peripheral vision and overall increased clarity, increased ability to navigate surroundings. So all sorts of things are possible even years later. So I want to share with you my resource page. I hope that this was important information for you. Again, you must learn all that you can about the eye so that you can help yourself the best possible way. And I want to share with you, I have a book to help you if you're at the beginning of this journey and need a starting place. If you want to listen to past episodes of my podcast, over which I touch on many topics that are relevant to people with ocular melanoma, I have my past webinars and videos. If you want to review a holistic approach to ocular melanoma, please check that out. That was done in the past, but we have that available. If you want to be updated on my future webinars, if you want to share things that you feel are important to you, and if you're interested in joining our small group, I encourage you that this is a great way if you feel you need more personal support, you want sort of more control, you want to help adjust how you're thinking about some of this. I'm here to help. I can teach you the tools, and there are some people who have tremendous benefit from this. And it's continued community and peer support. And I also help you with mindset, reducing anxiety, and people have greatly benefited from this. Now, I want to open this up to you to be able to share questions that you have, and I would like to bring on any of you as panelists. If you are interested in asking questions, I am at your disposal. So please raise your hand if you would like to ask me something. I'm more than happy to address any questions at all. Let me bring this up here. So I'm going to bring Dana here. Hi, Dana. Do you want to unmute yourself? Feel free to turn on your camera if you like. Totally up to you.
I will leave it off right at this moment.
No worries.
I had a question for you. So I read your book and I've listened to some of your podcasts. I'm scheduled for a brachytherapy surgery on May 13th. And I know my surgeon is not using the silicone oil that you do. And I just wanted you to kind of expand on maybe why someone would choose not to do that or I'm kind of confused as to I know you said the benefit of it, but what if I don't have it? What is the outcome?
So, I mean, that's a great question. And that comes up. In reality, most of the people who practice ocular oncology are not retina surgeons. So it's a technique that, when you do vitrectomy to replace the vitreous humor with silicone oil, you have to be comfortable operating in that space. But I've also found that many ocular oncologists who are surgical retina specialists, they keep their tumor practice and retina practice totally separate. It's an evolving thing that we have an increasing number of ocular oncologists performing this.
Mhm.
The benefit that the oil gives is that it minimizes radiation exposure. And, there's no way we can know how much benefit or what would have happened if you had it or didn't. But on principle, since it lowers the amount of radiation exposure to the healthy non-tumor tissues, that's why I do that at our center. You will still have the melanoma treated. There is still a great possibility for maintaining vision. It's just the most important thing is to make sure that you have your melanoma treated. And you can certainly bring up the subject with your ocular oncologist. I know that there are some people who are starting to do this, and it may be a new thing for your surgeon, but it definitely reflects a variability in practice patterns and in techniques that ocular oncologists use.
Great, thank you so much.
You're very welcome. Now, let me, uh, all right, we have Peter here. Hi, Peter. So nice to see you here. Want to unmute yourself?
Okay. Can you hear me now?
I can hear you now. Yes.
Okay. Um, so I had cataract surgery while I was still seeing you, because it was getting so cloudy you couldn't see the back of the eye, and that was in the affected eye, and that was fine. Um, my Kaiser doctor, um, a couple of years later, suggested that I have the cataract surgery in my unaffected left eye. Um, and he talked me into a multifocal lens. And he didn't promise. I know doctors don't promise, but he encouraged me to do it because he said I could get out of glasses completely. And all my friends and relatives said, "Yeah, do it. The extra money, blah blah blah. You can afford it. Do it." So I did it, and my life has been a living hell ever since then. Right after the cataract surgery with the multifocal lens, I'm getting all the stuff you were talking about, and this was immediately the flaring. I don't want to drive at night anymore. I get the ghosting, and uh, it's just, it was just bad. 3 months after that, I got a second opinion because I wanted him to take it out. I wanted him to remove that and replace it. And he was very hesitant after the surgery to touch anything. So I got another doctor there, and he agreed. And we had a procedure, and he pulled and tugged and yanked and did everything, but he was very careful because he said, "I don't want to screw up your only good eye." Uh, so after 20 minutes of pulling and tugging and everything, he gave up. But it's not getting any better, and it's just ruining my life at this point. So I went back to him. This is like 3 years later now, and he's going to try again. Uh, there's a procedure he said he's going to like try and later this coming week, he's going to do a cut, a little laser cut to try and get his instruments in there to try and maneuver the lens and maybe remove it that way, just to put in a monofocal, just a regular focal lens, which I should have had done originally. You have any suggestions or something? Uh, I don't know if this is going to succeed. He says there's a very small, minor chance of any damage to the eye because, again, I only have one eye left. But this is really affecting my life. I don't want to drive as anymore because the street lights and then the oncoming lights from the headlights from the cars. So my wife is basically driving at night at this point, and my vision's not good with this. So is it normal to tr is it normally an easy thing to try and get a a lens out, a cataract surgical placed lens out and replace it with another one? Because it seems as though they're having a difficult time because I guess those legs that hold it in place and everything. You got any suggestions or anything
You
like that?
know, it sounds like you've had kind of a rough patch of, things that are surprisingly disappointing. And,
Yeah.
for hearing everything, I would recommend that you also see a retina specialist because if a retinal surgeon is participating in a lens exchange, they can also clean out everything in the back, reduce the tugging and the pulling of the vitreous humor. And they also, a lot of retina specialists now put in secondary intraocular lenses um, in in ways that are very safe. So maybe bring up with this surgeon who is planning to do this procedure to that you'd like to consider having this done in combination with the retina surgeon who can also do a vitrectomy. No,
Is Dr. Cedar a retinal specialist? Because
yes.
okay.
Yeah.
Okay, so
So
I
in
just saw him on my every 6 month about a month or so ago. But okay, so maybe I'll talk to Dr. Cedar about this.
Yeah, really describe the concerns you're having, like with your
Yeah,
vision as much as possible,
right,
and see if Dr. Cedar would consider being present or doing a vitrectomy as part of it. It's hard to know. I'm just giving you overall suggestions, but
right.
you have a team of people who can help you.
No,
So
yeah, yeah,
reach out to Dr. Cedar.
right. Okay. Thank you.
Because there should
Good.
be a solution to this. This is a solvable problem. You just need to go about it safely and have the right people. This is not
Okay.
something that you're going to be stuck with forever.
Yeah.
So
Okay.
I would do that.
All right. Thank you.
Of course, absolutely. Let me let's move to, all right, Sandra. Hi there. Do you want to
Oh,
unmute yourself?
hi, can you hear me?
Yes, I can hear you clearly.
Great. Well, it's so
I can
wonderful.
see you too. How are you?
So good, good from all the way across the miles. It's so great to see you and hear your voice. I have a question for you. Um, when I first had my brachytherapy with you, I remember reading up and speaking with you and just gathering information about this cancer. And at least at the time, they said that it was unlike other cancers in that there was never a time when you could just sort of relax and be like, okay, well, I'm at the 5 year point and I can, exhale now. And, hopefully at this point, it's less likely to come back or something. So I heard that that's not the case with this one and that it's forever in danger of returning equally, from year to year. However, when I was last visiting with you, somebody there told me that now that I am actually at the 10-year mark, that I am able to come back only once a year as opposed to every 6 months. So that made me feel like, oh, okay, well, maybe there is like a little bit of like a relief kind of situation now. So I just wanted to double check with you about that.
Oh, yes. So, the more time that goes by, the lower the risk. And the
Oh.
reason we're just cautious is because there have been some cases where it's been like 25 years out and someone is discovered to have metastasis. Now, we have to go back and look at your particular situation and your melanoma and really going back to how big it was from the beginning. And when people are diagnosed with a very small melanoma, meaning like this size is a variable, but when people have the smallest of the spectrum, like they're like 2 millimeters or less in thickness, those people were actually seeing, and certainly with our medical oncologist at UCLA, we're starting to sort of graduate people away from doing regular scans after, like, you're at 10 years now. That's, I remember, I know what your tumor is from my memory. So I'm a little bit jaded here. I'm just gonna so if your tumor started off on the bigger side and it was sizable, I would continue doing scans indefinitely. If you started off with a melanoma that is less than 2 millimeters, is really small, and it was just like, it's just starting to change, we're going to treat it. Those are people who we're finding now tend not to need forever scanning. And no one knows 100%, but I do know that our medical oncologist is starting to have those, like, after 10 years, after 15 years, really discontinue screening. And I'll just
Hmm.
say, once in a while, you could still maybe do like a liver ultrasound, something that's very non-invasive, that's still, so you can check in and make sure your liver is doing well. So
Okay.
there is light at the end of the tunnel, I feel like
Okay.
saying to you. And I would just bring it up with the medical oncologist too, especially if you are with someone who is very experienced. You'll find
Yes.
that they know not, I find that if you have someone who's not experienced, they tend to discount screening. But if you're with someone who's very experienced and they have this experience of people 10, 15, 20 years, I'm finding that we are actually reducing the screening for people who start off small.
Wow, that's great. And so you feel like at the 10-year mark that there is definitely hope that this will not metastasize or return.
So there's hope. I feel like I don't know if 10 is the number. I don't know if it's 15 or, we don't know the number, but it seems like after a lengthy period, you can discuss with the medical oncologist the possibility of adjusting your surveillance. I think that's very reasonable because we need to treat everybody slightly different because we're not exactly identical. In when we
Right.
don't really know, it's better to err on screening, but if there's some other factors, um, let's put it all together and look at everything.
Okay. Thank you so much.
You're welcome. It's great to see you.
You
Thank
too.
you.
Take care. Bye.
Okay. I'm gonna give the floor to Leslie here. Hi, Leslie.
Hi there. It took me a few
Oh,
minutes to get. I'm behaving. I see you tomorrow to get the brachytherapy removed, but I've been making it through the week, and I can't seem to get my cat to stay away from me. So
okay. Your
here
cat
we
will
are.
be okay.
Yeah, at this point. So she's but I wanted to make a comment. Just thank you for putting this webinar together and all of your educational resources. It's above and beyond from what clinicians are obligated to do, and so I just wanted to thank you for that. And then I wanted to just make a comment on the value of meditation. I've never been a person that slows down very well, and the idea of sitting and breathing and just trying to allow my sympathetic and parasympathetic nervous systems to relax and calm. I did not realize how important that would be getting through this week. I didn't recognize how much discomfort there was, and there were many nights where I just laid in bed with my head down on the pillow, focusing on, like, I had to learn to meditate, and I can't overemphasize how powerful and helpful it's been to just get through this week.
Well,
So,
thank you for sharing that as someone who is experiencing benefit. It's incredibly helpful. And if you've done it now, continue to do it. Even when your eyes feeling more comfortable and you've recovered, make that part of your life habit. It is so, so beneficial.
and now that I'm learning that this isn't a one and done, it's amazing how we've gone from cancer as this bad boogeyman to now it's a chronic disease and we manage it like any other chronic disease. So, in for the long haul, but I just wanted to say good morning. I'll see you tomorrow, and thank you.
Well, thank you so much. I appreciate you speaking up and sharing. We'll see you tomorrow.
Bye.
All right. So we have Holly coming up. Hi there, Holly. Please unmute yourself and we'll hear what you have to say.
Can you hear me, Doc?
Yes.
Actually, I'm Holly's father. I had, it's for me. I had trouble logging in. She had to do the link for me. So I apologize.
No, that's no problem.
Um, my first of all, as that previous lady mentioned, thank you so much. One of the things I got out of this seminar was your approach always to positive thinking. It is always a good reminder to give us that checkup from the neck up. And I found everything you said to be very helpful. I do follow all the procedure, all the tips that was given to me from UCLA. And after seeing the oncologist every 6 months, I actually get see Dr. Cedar too. He does my eye check and since I'm not with UCLA, all the in-depth, and I get the good updates all the time that it looks very clear, Phil. It's healthy and all that. My one question is, my vision in my right is 2400. And you'd always said it was a very big lesion, Phil. It was in the cornea, which is very close to the retina. And I guess I'm an optimist at best always, wondering, is there something that can improve the 2400? I'm very happy that I'm alive today and everything you've done for me. But when I sit on your seminars, I get optimistic and to listen to this saying, I don't know if I'm telling Dr. Cedar or Dr. Gregory, who I go see, my two doctors, enough. I don't have issues. The one is that maybe I'm a little more sensitive to light than I used to be. But besides that, my left eye is of course 20/20. And I just wondered, are there things I'm missing? Because I don't get to see you. And I felt, boy, what a wonderful opportunity. I could ask you this one question and then go around my life.
Yeah, great idea. So, I would say that when you're at your ocular oncologist appointment and they are looking over things or looking at the testing, you can say, this is what I would do, just because I would say, why is it that I'm seeing whatever it is? If it's 2400, the number, just can you explain to me why this eye sees 2400? And if you just ask an open-ended question like that, your doctors are going to have to verbalize to you what it is, what structures are involved. Um, you can ask about things like, how is my intraocular pressure? Do I have any sign of glaucoma? You can ask these things that are less obvious. So, I would always say, can you explain to me why I'm seeing X? And that in itself will probably open up a whole additional few minutes of knowledge that you will have about how that eye is doing. And you can also follow up every statement by saying, is there something I can do about that? Is this treatable? So you have to dig a little bit if you think there might be some more there that is, you want to leave no stone unturned. So just ask that question. And I think you'll get much more information than you would if you just were don't ask anything. And especially if you're wondering if there's anything more you can do. So I would just ask that. Why am I seeing 2400? Can you explain to me? And I think you're gonna be surprised by what you might learn about how you're doing. So do ask. And then also you can say, can you just show that to me on the pictures? You can ask that too. And that will get your doctor to engage with the images in front of you to help explain what they're seeing. Something valuable will come out of that. So that's what I'd recommend that you do.
Thank you, Dr. McCown.
Absolutely. Thank you so much. Okay, well, it looks like that's our questions. Let me see if there's anything else. Let me look in our Q&A here. Okay, got some questions here I will answer. What determines how long to keep silicone oil in the eye? So at UCLA, we use silicone oil because it is denser than our natural vitreous humor. And when we fill the ocular cavity with silicone oil, it reduces the radiation exposure to healthy non-tumor tissue. So when I decide to take that oil bubble out, I usually want to see that the melanoma has responded and that there is no further retinal detachment, because that oil bubble can also hold the retina in its proper location as the tumor dies, and then that fluid under the retina gets reabsorbed once that tumor is no longer active. In most cases, that's at least about 3 months down the road. And I like to do that procedure when the eye is not red, there's no swelling, when everything is all comfortable and healed. That's when the surgery is the most straightforward. And usually when the oil comes out, we see some improvement in your vision. Here's a question. I have had an enucleation and now have a kaleidoscope effect on the vision in my remaining eye. What is the reason for this, and can anything be done? So this is a difficult question to answer without examining your remaining eye. So what I would do is you need to bring this up with your ophthalmologist and describe in a lot of detail what you mean by kaleidoscope. This could be related to your lens. It could be, a kaleidoscope effect. Is it static? Is it changing? Is this transient? Is this something that comes and goes? So I would encourage you to bring this up with your ophthalmologist, plan to describe it in extreme detail, like the timing, location, what makes it better, what makes it worse, and see if you can get some answers. That's what I would recommend. Well, I appreciate all the thank yous for doing this. I think this is very important. I really believe in information. Makes a huge difference. Somebody's asking about double vision. So, double vision at the time of your surgery is pretty normal. However, if double vision persists, particularly when you're looking straight ahead, we call that in primary position. If you still have double vision in primary position 3 months after your brachytherapy surgery, I would ask for a referral to a strabismus specialist. Strabismus means disorder of the extraocular muscle. It's a muscle specialist that you need to see. So ask for a referral for a strabismus specialist or strabismologist or eye muscle ophthalmologist, and have that person evaluate you to figure out what you can do. But definitely give it some time. But if it's still there after 3 months, when you look straight ahead, it's important. I have a person asking, I'm 5 weeks post brachytherapy and still experiencing fatigue. Yes, this is very normal. I did an episode on my podcast about sort of post brachytherapy fatigue, and it's very normal. We don't know exactly why people experience this. It seems to affect people in any size treated melanoma, but it does go away. It will be gone, and It's something you just have to be aware of. You can slog through it, or you can take it as an opportunity to give yourself a break, but know that it is temporary and it will be gone. It tends to happen about a month or so after, and it can linger for as long as about 8 weeks, but in most people, it will resolve sooner than that. Um, I have a person asking about doing eye exercises. You know, when you use your eyes in regular everyday activities, you have them both open, that is plenty of exercise. When you look around your home, when you're doing things in the kitchen, you're doing work, that is exercising your eye probably more than doing things where you follow your eye with your finger or a pen. So I say, do not patch the eye, use them together, get comfortable, even if your vision is off, just get comfortable incorporating it into your overall sight. All right. Wonderful. It looks like we've come to the end of our time. We ran a little longer, but I hope that this was useful, and I'm going to put the recording of this webinar up so that you can review this again, or if you know anybody who may benefit from this, please share. Thank you so much, everybody, for joining me today. It was wonderful to be able to share this with you. I hope that this information is going to help you do as well as you possibly can. Thank you.